the hole in the iris is pupil. If we look at the retina, this is a sketch of the inside of the eye. The retina is made of two layers, pigmented layer and neural layer. The posterior 3/4 has a neural layer. Then the neural layer will stop in a zigzag fashion. This is called ora serrata. Then the most anterior 1/4 is pigmented only, no neural layer. These are the three layers. Okay, this is histology of layers of the eyeball. This is the choroid. Now, if we look here, what do we see? We see a single layer of cells containing melanin. Then this plus the neural layer is the retina. This is diagram of the basic layers of the retina. This is the pigmented layer. This layer here is the layer of rods and cones, the receptors for light. It has nuclei. See, rods and cones are cells. Then the middle layer we have neurons. They are called bipolar neurons. And then ganglionic neurons. Ganglionic neurons will make the optic nerve. So the story starts here. Light goes through the retina down to the outer layer. Then things get processed, changed from light into action potential, and the ganglionic layer will send axons to make the optic nerve. These are rods and cones, nuclei and discs, stack of discs. This is scanning electron microscope of rods and cones. If we look to the inside of the eye, which is a very important, it's called fundoscopy or retinoscopy. We have to see the optic disc because the optic disc is so important. Okay, you can see this circle here, and there's a dark structure here. This is the head of the optic nerve. Okay, this is the very shiny center is called optic cup or physiological cup. And then you see the little bit darker area, it's called the macula, and in the center, even darker, this is called fovea. Fovea is the area of maximum vision. The image should fall on fovea. So this is the optic disc, this is the optic cup, 1/3 of the optic disc. And this is the macula, and the center darker area is the fovea. Macula and fovea. This is a normal optic disc, sharp edges, blood vessels radiating from the center, and this is the macula, and here is the fovea. Again, normal fundoscopy. This is the fovea, a depression. Okay, very nice looking choroid, and the retina gets thinner in the fovea. Special stain for the fovea. This is bad macula. Diseased macula. If you look at this, is a normal optic disc, blood vessels radiating from it. Normal cup and larger cup, optic cup. This is the normal. You see, it should be 1/3 of the optic disc, and this is more than 1/3. This is happening when intraocular pressure increases. Pressure is applied on the optic disc. The optic cup gets larger. The retina is the only place where you can see blood vessels. Here is nipping of arteries over veins. And arteries are harder and high pressure in them, and they press on the veins. Okay? This is what happens in hypertension. In every patient of hypertension, you should examine the retina, fundoscopy. This is a normal optic disc and fovea, and this is in case of diabetes. Exudates. So every diabetic patient should be examined. Okay? Normal and diabetic. No sharp outline. That is a big problem. No optic cup. Sharp outline has been lost. Blurred optic disc. This is even more bad. Why? Well, because of increased intracranial pressure. This is a normal optic disc. This is papilledema. Okay. CSF is around the optic nerve. Optic nerve is an extension of the brain. Therefore, CSF is around the optic disc. Increased intracranial pressure. Check optic disc. It will result into optic disc edema. It's dangerous. Loss of vision. Next. Remember, always examine optic disc if you suspect increased intracranial pressure. This is a normal optic disc or optic cup. This optic cup is much larger. Okay, should be 1/3. With increased intraocular pressure, the optic disc will get, optic cup will get larger and larger. This is an angiogram of the retina. You can see the blood vessels are well spread. You can see that this is the macula and this is the fovea. This is infarcted, no blood vessels around the macula and the fovea. Okay, this is normal, this is infarcted area. These are aneurysms of arteries in the retina. Now, this is a summary of the retina. You can see it on your mind map. Okay. The optic nerve is an extension of the brain. This is the optic nerve here, axons of ganglionic cells. This is a cross-section of the optic nerve, blood vessels in the center, central retinal arteries. This is the optic margin, is the optic cup. This is subarachnoid space, bringing CSF from the brain down here, because the optic nerve is an extension of the brain. That's the optic disc, optic cup, blood vessels. This is the optic disc, this is the optic nerve, and the subarachnoid space is extending down to here. Sorry, one time.
Just give them the notes, yeah.
Just 1 minute, okay? Is the optic nerve a peripheral nerve or is it part of the brain? Now, cross sections and electron microscope show that it has many myelinated, okay, cross section of nerve fibers. Where are we? If you remove the roof of the orbit, if you remove the roof of the orbit, you will see this is a crista galli, this is the eyeball, this is the axis of the eye, and here's the optic nerve. Okay? I don't want. Yesterday we were studying the eyeball, the structure of the eyeball, and today we will be discussing the problem of people who have different positions of the eyeball. يعني حول، تعرف شو حول؟ Squint or strabismus. If we look at this young person, are both eyes in the same position? The answer is no. If we look at this spot of light, it's in the center of the pupil. If we look here, it is not in the center of the pupil. It's at the margin of the iris. Therefore, there is a problem. If you look at this person, you can see quite clearly that this eyeball is deviated laterally, while this is in the center. Such person will have diplopia, double vision, because you know that the macula is the most sensitive part of the retina, and the two images fall on different areas, therefore the brain is going to interpret two images. ليش فتحته؟ اوكي شايفين؟ Yeah. Lots of people have different. تفضل. والله ابني هاي مش شغل. مش شغل يعني. والله هاي تعليمات العميد. Okay. Some of these squints or strabismus are mild. Some of them are quite severe. And we need to know what's the story. We need to know what is the story. This person has this eye in the center when he is asked to look forward. Looking forward is called the normal gaze. So he looks in his left eye straight forward. His right eye is looking down and lateral. So one of the muscles or one of the nerves is not working, and the balance is disturbed. If you look at this young person, you can see that the right eye is in normal gaze, normal position, and his left eye has deviated towards the nose, or adducted, or it's in. If you look at this kid, you can see that both eyes are directed towards the nose. There is a problem. It's either of muscles or problem of nerves. شايفين الصور بوضوح؟ This young girl also has a problem. Her left eye is up. This person has a severe problem. يعني عين في مكة وعين في القدس. Okay. This is a quite complicated problem. This kid also has a problem. This eye is deviated medially. Can glasses correct some of these squints or strabismus? The answer is yes. Not all of them, few of them. If you correct vision, then the eye will come back in its position. This eye is up and in, up and medial. These are problems. And we are what? We are asking ourselves, what is the problem? Because we are problem solvers, aren't we? Doctors are problem solvers. People come to you saying, I have a problem. And you are what? You are a problem solver. If you don't have enough science, you have what? You have a problem as well. So if a person who has a problem meets a person who has a problem, there is no solution. This is what we always ask ourselves. What, when, where, how, and why? This is the normal gaze looking forward. If you look at the orbit and we take the roof of the orbit, والله يا وليد ضيعت 10 دقائق من يلا. Thank you. If you take the roof of the orbit, you're going to see, here's the eyeball, right? Here is the middle cranial fossa, and this is the optic nerve. You can see this white structure. This is called the common tendinous ring, or ring of Zinn. This is where muscles take origin, and they insert on the eyeball. This muscle is running lateral, and it is straight, therefore it is called lateral rectus. أخذت غياب وفليته يعطيكم العافية. Rectus because it's straight, and lateral because it is lateral. This muscle is superior rectus, and this muscle is medial rectus. If you look at this diagram, these are the two eyes. This is the ethmoidal air sinus. This is the common tendinous ring of Zinn. This muscle here is lateral rectus. This is superior rectus. This is medial rectus. This is the inferior rectus. And this muscle is called superior oblique because it is superior to the medial rectus, and it turns around the trochlea and comes back and gets inserted into the eyeball. Therefore, this is the superior oblique. On the other side, we can see the inferior rectus, and there is another muscle which is called inferior oblique. So at this point, we have 6 muscles. If you look at this diagram, this is the common tendinous ring, the origin of muscles of the orbit. There is this muscle which is not taking origin from the common tendinous ring. It is taking origin from lesser wing of the sphenoid. And it runs on top of superior rectus, and it comes anteriorly, not inserting on the eyeball, but inserting on the upper eyelid. Therefore, when it contracts, the upper eyelid is elevated. Therefore, we call it levator palpebri superioris, levator of the superior eyelid. This muscle has part of it involuntary and most of it is voluntary. This is the inferior oblique. If you look at this diagram showing the eyeball in the orbit, and the muscle on top of the superior rectus is levator palpebri superioris. This is superior rectus. This is the trochlea, and this is the superior oblique turning around the trochlea and inserted on the eye. This is the inferior oblique. The inferior oblique is taking origin from this area here, which is the floor of the orbit. It runs lateral and inserts on the eyeball laterally. This is the common tendinous ring, and you can conclude that this is the medial rectus, inferior rectus, and lateral rectus. This is the position of the common tendinous ring, and we can see that the opening of the superior orbital fissure is within the common tendinous ring. If we take the roof of the orbit, we can see this muscle on the medial side, most superior. So this is the superior oblique muscle, which turns around the trochlea and comes back on the eyeball. This is the first muscle we see superiorly, therefore this is the levator palpebri superioris. Now you are acquainted with the roof of the orbit. This is the levator palpebri superioris flapped, removed to the front, and underneath it we see superior rectus muscle. This is the superior oblique muscle. Again, in this view, this is the superior oblique muscle around the trochlea and coming back to the eyeball. This is the lateral rectus. And this is the oculomotor nerve. Sorry, this is the abducent nerve coming to the lateral rectus. Medial rectus, because there you can see it's not going around the trochlea and it is deeper. And this is the inferior rectus and the lateral rectus. This is the oculomotor nerve coming into the orbit. This is what? Medial rectus, inferior rectus, lateral rectus, oculomotor nerve. This yellow area is the orbital septum. You know, the orbit is not open to the outside. There is an orbital septum, and the eye bulges through the middle of it. If we remove the orbital septum, we can see the muscles inserted into the eyeball. This is the lacrimal gland, upper part of the orbit. Medial rectus, superior oblique, superior rectus, lateral rectus, inferior, and this is the inferior oblique coming from the floor of the orbit, going laterally, inserting on the eyeball. If you take the eyeball out, this structure in the center is going to be the optic nerve. And you can see superior rectus, levator palpebral, lateral rectus, inferior oblique, medial rectus, and superior oblique. A CT scan, coronal, you can see these. This is the optic nerve, and you can see these muscles. Lateral rectus, medial rectus. When this person is looking forward, there is a balance between the tone of the muscles. We're not using any muscle at this moment. The tone of the muscles, you know what a muscle tone is. The little contraction at rest. Muscles, when I'm standing, okay, there is a muscle tone. Let's look at this muscle. It is the superior rectus. This is the insertion of the superior rectus. This is the result of its contraction. This is the equator of the eye. Now, because these muscles on the medial side are longer than these ones, longer muscle fibers produce more range of movements. Therefore, what is the action of this muscle? It is going to be up and medially, okay? Now, the rotation, we are going to omit the movement of rotation because it complicates the picture. Therefore, the major action is up. The minor action is in. If you look at this muscle here, this is the inferior rectus. This is the horizontal line, this is the action of the muscle, and this is the insertion. Again, the medial muscle fibers are longer than the lateral. Therefore, this is going to pull the eye as a major function down and as a minor one to the inside. Let's look at this muscle. This muscle is the inferior oblique, and we have just seen the inferior oblique. It takes origin from the floor of the orbit and inserts on the eye laterally. This is the line of action. This is the equator of the eyeball. Therefore, the major function is up and out. Opposite the action of superior rectus, which is up and in. This is up and out. Out means lateral or abduction. Okay? Now, this muscle here, the superior oblique that we talked about, this is the equator of the eye. This is the action of the muscle. Okay, the eye is going to look down and out, but in this case, this muscle is going to produce intorsion as well. Intorsion means, like for example, my right eye will move towards the nose. The lower part will move towards the nose, because if we cut the nerve supply, we're going to have diplopia. Lateral rectus is simple looking lateral. Medial rectus is simple looking medial. One major action. So some muscles have a major action and a minor action, and the lateral and medial recti, they have one major action. This is not a chemical formula, but it is arranged so that we can know quite easily what muscles are supplied by what nerve. LR, lateral rectus, is supplied by 6th cranial nerve, the abducens nerve. Superior oblique is supplied by the 4th trochlear, and the rest 4 muscles are supplied by oculomotor. LR6 is 043. This person is looking to the right, so he is, in the right eye, he is using the lateral rectus by the 6th nerve. And the left eye is looking medially, and he is using oculomotor nerve. 2 different muscles, 2 different nerves. This young kid is looking to the left, so in the right eye is going to move toward the nose, therefore he's going to use what? Medial rectus, oculomotor, and the left eye will look lateral, and he's going to use the lateral rectus, 6th nerve. Looking up and to the left, superior rectus, the main function of superior rectus is up and medial, okay, up and in. So if you want to test an eye, okay, whether the superior rectus is working or not, you hold a pen and say, look up and medially. If he can follow, then you are testing this. Looking down and to the left, also one muscle, oculomotor, one muscle, trochlear. Okay, 2 different muscles, 2 different nerves. Looking down is more complicated. Looking down is inferior rectus and superior oblique. You know, the inferior rectus is down and in. Okay, superior oblique is down and out. Therefore, the in and out, they cancel each other. So it is same 2 nerves, but 2 different muscles. Up is the same, using 2 different muscles, 1 nerve. This is looking up and to the right, down to the right. These are the axes of eye movements. These are the muscles. This is the medial side. Superior rectus is what? Up and in. We're going to ignore this intorsion. Medial rectus is simple medially. Lateral rectus is simple. Inferior rectus, okay, is down and in. Superior oblique is down and out. Inferior oblique is up and out. Here are the muscles in balance. Normal gaze. What about this person? This person is asked to look straight. Okay, so this is the normal eye. This eye is looking down and lateral. Down and out. Okay, missing what? Plus, there is a dropping of the eyelid. So that is oculomotor nerve palsy. It is only the superior oblique and the lateral rectus are working. If you see this patient here, this is a normal eye, right? The left eyelid has dropped. Levator palpebris superioris is not pulling the eyelid. So this is a lid drop. Levator palpebris superioris is not working. Put your finger and push up the eyelid. You can see the eye is looking down and lateral. This is typical description of oculomotor nerve palsy. Same condition. Normal eye, lid drop, elevate the lid, the eye is looking down and out, down and lateral. This is less severe case of oculomotor nerve palsy. This is the normal eye. Look, compare the eyelid of the right and the one with the left. The left is a little bit dropped. The eye is looking down and out. The same person, we want to test what is going on. So we ask him to look to the right. The right eye went right. The left eye did not. Okay? You ask him to look to the left. The right eye looked to the left and the left eye looked to the left because there is no problem looking to the left. When you ask him to go up, to look up, the right eye looked up, the left eye didn't. When you ask him to look down, the right eye looked down and the left eye didn't. So when we have a problem in looking at different directions, the nerve that supplies different muscles is the oculomotor. So we know this is an oculomotor nerve problem. Same condition as the two we saw before. Lid drop, the eye is looking down and lateral, oculomotor nerve palsy. What is the problem with this patient? Here is asking the patient to look forward, okay? When you ask him to look up, okay, this eye looked up and this one also looked up, but not good enough. These are minor changes, you will get used to them. Okay? When you ask this person to look down and to the left, this eye looked down and to the left. This eye didn't come down. So let's skip this. This is more obvious. Looking straight forward. Okay? You ask the patient to look up. This eye this eye looked up, this eye didn't. When you ask to go up and to the left, this eye didn't go up. When you ask the patient to look to the left, okay, there is a little difference, but we are not concerned about it now. When you ask the patient to look down and to the left, this eye went down and to the left, but not the same as this one. The most obvious case is here. Ask the patient to look down, straight down. This eye looked straight down. This eye didn't obey. This is oculomotor nerve palsy. What's the problem with this young kid? This is normal. This eye is up and in. What is missing is down and lateral, down and out. Which muscle is putting the eye down and lateral? Is the superior oblique. Okay? People who have superior oblique problem, they compensate by turning their head. We will know why. If you look at this person testing his eyes, this is looking straight forward. There are differences, but you need to be very shrewd observer to notice this. Ask to look up, things are well. Up and to the left, things are not well, because this eye went up and in, this eye not the same as this one. When you ask him to look to the left, no problem. Ask to look down and left, no problem. Here's the problem. You ask the patient to look down, this eye obeyed very well, and this one looked down but went medially, went in. So this is the problem in the right eye. What about this young kid? This is normal eye. This eye is deviated in. It needs to be pulled laterally. So the lateral rectus is not working. The lateral rectus is LR6. Okay. Not going into details, but these are very good examples of training. Now, you know why there is a red star here? It's because you ask the patient to look to the left. The right eye went to the left. The left eye didn't. So which muscle in which side is affected? It's the lateral rectus of the left side, supplied by abducent nerve. Okay, now, simple review of muscles. One levator, 4 recti, 2 obliques. Okay, the levator has 2 parts. One is smooth and the major part is skeletal. This levator is called levator palpebris superioris. 4 recti, superior, medial, inferior, and lateral. 2 obliques, superior oblique and inferior oblique. The levator palpebris superioris acts on the upper eyelid, not on eye wall. Superior rectus looks up and in. Inferior is down and in. Superior oblique is down and out. Inferior oblique is up and out. And in torsion. Okay? End of the story. Now we will be talking about the nerves of the orbit. So we have an idea about these muscles. Again, this person has different positions of the eyeball, but we will be looking and concentrating on the nerve supply of these muscles producing these problems. This young lady has this eye deviated medially or in.